Recording in progress.
All right, we are now recording to the cloud. It'd probably be pretty good if I shared the screen also to the PowerPoint slide. All right, can everybody see that? Is everybody able to see the PowerPoint? It lagged a little bit on me, so I was trying to make sure that it did not for all of you. Great, great. Okay. Then we shall move on. All right, so today's lesson is going to cover Chapter 18, Cardiovascular Emergencies. In this lesson today, we'll be going over some of the instances of injuries and illness that'll cause a cardiovascular compromise, and how we can detect and mitigate those issues. All right, looking over the National EMS Education Standards of Competencies. There's 5 pages of. All right. So the AHA estimates that one person has an acute myocardial infarction or an AMI in the United States approximately every 40 seconds. Every 40 seconds. That's crazy, isn't it? Heart disease has been the leading cause of death of Americans since 1900. The leading cause of death. So, so how do we go about reducing these cardiovascular deaths? Well, I'll tell you. We do that through better public awareness, early access to EMS, so getting them there faster, exercise, yep, that would help, proper diet, increased numbers of lay people trained in and willing to do cardiopulmonary resuscitation or CPR, public access to defibrillation devices, recognition of the need for ALS or advanced life support services, transportation to hospitals that can provide coronary catheterization and post-arrest care. All right, so public access to defibrillation devices, so like AEDs, correct? What are some other things that are being implemented if you've been studying around? That are being implemented in the United States as far as public access to devices, and also to the increased number of lay people trained. What are some things that's been done to mitigate that issue or to further it? AEDs are everywhere now. That's right. Has anybody ever heard of the Pulse Point app? Pulse Point? So, Ms. Church, can you explain to us, or have you ever used it, or do you know a lot about it? Or have you just heard of it? Yep, tells you when that's correct. Tells you when a cardiac arrest happens nearby you, or when somebody needing some sort of life-saving care is right nearby you, right? Like cardiac arrest mainly. It can also tell you where AEDs are located. So it'll tell you where AEDs are located well, and this is all in the form of an app that you get on your phone, and it pops up as an alert. It's pretty amazing. What are some other things that we've done publicly or for the public to increase the number of people that are able to do CPR? So we do the hands-only CPR campaign now. Now they have it in commercials, even the hands-only CPR. It's starting to get dark in here. Uh-oh, Papa John's is telling me I need to order a pizza. I might do that, Papa John's. All right, so you got the hands-only CPR. You got better accessibility to CPR type classes. They're open for the public, or open to the public now. Plus many, many other things that we've been doing. But yeah, by far, I've been very impressed with the PulsePoint app. I've always felt it was that was a needed source. All right, so anatomy and physiology review. Thank you for letting me know that. I'll write that down right now. My apologies for that, Miss Hughes. I will fix that up as soon as I get back into the grade book. I appreciate it. If you're going through your grades, this is why I was talking about when we first started talking about this transition. Make a copy of your grades or a picture, a screenshot of your grades, so that if we need to cross them over, so that you have those as well. If you're looking through your grades and then you see an error in the ones that I put in, please let me know so that I can make that adjustment as quickly as possible. Okay? And I will do that. All right. So the cardiovascular system consists of the heart, the blood, vessels and blood, the heart, blood vessels, and blood. Let me slow down there for a minute. Some of the structures of the heart. The heart is a muscular, cone-shaped organ whose function is to pump blood through the body. It's a pump. If you think of a mechanical pump, like a pump for a car, or for like a pump that's in a barrel, or the pump that's in a fish tank, or the pump or a hydraulic pump is probably the most closest thing that I can describe to it. Then that is basically what the heart does. And anything that can go wrong with a pump, like a hydraulic pump, can also go wrong with the heart. We just call it something different. And I'll go over that a little bit as we go. So the heart muscle is also, it's referred to as the myocardium. And the The pericardial sac, it's a very thick, fibrous membrane that surrounds the heart. Okay? You want to go under here? Sorry, my dog is scared of storms, so he's trying to put himself underneath my desk. The visceral layer of the pericardium, it lies against the heart. We call that the epicardium. Okay? The pericardial fluid reduces friction within the pericardial sac. So there's a little bit of fluid in there so that it reduces that friction while it's pumping. But if too much fluid gets in there, then we get into other complications where it might call for a pericardial centesis or something of that nature. It could also cause tamponade if it gets too much in there, or if there's too much friction, might cause myocarditis or lots of other things. Pericarditis. Alright, so endocardium is a smooth inner lining of the chambers of the heart and the surface of the valves. Each atrium receives blood that is returned to the heart from other parts of the body, right? Each ventricle pumps blood out of the heart and into the other parts of the body. All right, the valves of the heart. It includes the atrioventricular valves and the semilunar valves. This also is going to include the tricuspid valve and mitral valve, the aortic valve, and pulmonic valve. So those two valves, or those valves, are going to be your semilunar valves. Papillary muscles in the ventricles contract to tighten the chordae tendineae, which looks like the strings inside. If you were to look inside the ventricles, it looks like a bunch of string attachments that are inside the heart. That's your chordae tendineae or chordae tendineae. So this figure here, it shows the anatomy of the heart to include the valves. There's the chordae tendineae there we were talking about. Your valves leak a little bit. Do they do anything for that just yet, or have they said that in the future there will be something that'll be needed for that?
Not yet. Just dogs. They leak just a little bit, but they said there's nothing they could do about it right now. You'd probably have to get like a valve replacement.
Was this due to, if you don't mind me asking, what was this due to? Was it something you were born with, or was this due to some sort of illness or anything you had in your past? If you don't mind sharing. Okay. So you should be able to ace this portion. Alright, so let's go over some coronary circulation. So coronary arteries supply oxygen to the heart, right? Coronary circulation emanates from left and right coronary arteries. The left main coronary artery divides into left anterior descending, or the LAD artery, and the circumflex coronary artery. This supplies blood to most of the left ventricle, and the intraventricular septum, and at times the atrioventricular nerve. So the coronary arteries supply oxygen and nutrients to the heart, right? So if you look there, A alpha is going to be an anterior view of the heart, and then B bravo is going to be the posterior view of the heart. If we were to get into 12 leads or 15 lead, we could actually go over how you could see that on a monitor. It is storming its rear end off here. All right, so blood vessels. Blood is transported through the body via the arteries. The aorta is the body's largest artery. The aorta. Arteries branch into arterioles, then capillaries, which eventually enlarge to form venules. Okay. Two large veins, the superior vena cava and the inferior vena cava, they return deoxygenated blood from the body to the right atrium. Blood from the four pulmonary veins enters the left atrium. Well, hopefully that does not happen here. Do not want anything to do with tornadoes while I'm trying to teach. That would just be aggravating. And inconvenient. All right, so blood flow through the heart. As you can see here, alpha, figure alpha, is going to be the flow of oxygen, poor blood from the venous circulation, is what it's talking about. B is in Bravo, figure B, is the flow of oxygen-rich blood from the pulmonary veins through the left side of the heart and into the aorta. It's blowing. All right. So let's talk about blood and its components. Blood consists of plasma, plasma red blood cells, or RBCs, white blood cells, known as WBCs, and platelets. RBCs contain hemoglobin, which binds to oxygen, we've talked about this before, and carries it to the tissues, all right? Which is subsequently what is read on an SpO2, the percentage of oxygen to the hemoglobin, right? So WBCs, also known as leukocytes, they fight infection, right? And then platelets play an important role in the blood clotting process. It's like that platelets are in that plasma. All right, so the heart and the electrical conduction system of the heart. Pumping of the heart occurs in response to an electrical stimulus that's initiated by a conduction system. The sinoatrial, or SA node, is the normal site of origin of the electrical impulse. It has an intrinsic rate of between 60 to 100 beats a minute. Right? Sounds familiar? 60 to 100 beats a minute, normally. The impulse spreads out through the rest of the conduction system, resulting in ventricular contraction, or systole. Not asystole. Asystole would mean A, the absence of, systole. So this is systole. The electrical conduction of the heart, it initiates an electrical impulse throughout the heart. The impulse travels through the 6 parts of the cardiac conduction system shown in the figure here. So to give you a better idea of how EKGs work, it works off of this electrical conduction system here. Okay? So when you start looking at electrical problems, what you're picturing in your head is this here. And if there's some slow conduction that's going on there, you just got to figure out where that slow conduction is at. So whenever you see the myocardial infarction or what have you, wherever you see that elevation, or wherever you see that de-elevation coming into play, then that shows that there's an issue with the electrical conduction to that part of the heart, which would indicate that there is a deadened area of the heart that is getting weak pulses. All right, if it's dead, that's infarct, right? That's ischemia. So at that point, that ischemic region is what we're trying to pinpoint. So each one of from the PQRST, all represents a portion of this electrical conduction system. Okay. So electrical properties of cardiac cells. Some of the properties of these are or 3 of the properties are going to be your excitability, which excitability is the ability of cells to respond to electrical impulses. Conductivity is the ability of the cells to conduct electrical impulses, and automaticity is the ability to contract without a stimulus from a nerve source. Because auto, right? Automatic. Automaticity. All right, so regulation of heart function. The heart's chronotropic state, dromotropic state, and inotropic state are controlled by the autonomic nervous system, or ANS. Receptors in the blood vessels, kidneys, brain, and heart, constantly monitor body functions to maintain homeostasis. The baroreceptors, baro being pressure, right, respond to changes in pressure, usually within the heart or the main arteries. Chemoreceptors sense changes in the chemical composition of the blood. Chemoreceptors, chemical. Baroreceptors, pressure. So the cardiac cycle is the process that creates the pumping of the heart itself. The cycle begins with myocardial contraction and it ends at the beginning of the next contraction. Systole is the contraction of the ventricles and the pumping of the blood into the systemic circulation. Diastole or diastole is the relaxation of the heart. All right, so here's some words that you need to be familiar with when we're talking about the heart. Because the more you learn about these, the easier it is to be able to do these field diagnostics of these patients. So, one term is going to be your preload, which is the amount of blood returned to the heart to be pumped out and directly affects the afterload. Okay? It directly affects the afterload, which is next. The afterload is the pressure in the aorta or the peripheral vascular resistance against which the left ventricle must pump blood. That's why the left ventricle is so strong, right? The cardiac output, so what that means is that cardiac output equals stroke volume times heart rate. Stroke volume times heart rate is going to equal your cardiac output. A little bit of math there for you. Factors that influence the heart rate are your... Come on. All right. So, some factors that are going to influence the heart rate are your stroke volume, or both. They're going to affect the cardiac output and the perfusion of the heart. Okay? So Starling's law, the Starling law of the heart is increased venous return to the heart stretches the ventricles to some extent, resulting in increased cardiac contractility. The Starling law of the heart. Ejection fraction. Now you'll hear about this a lot throughout your career. Ejection fraction is the amount of blood returning to the right atrium, and it may vary from minute to minute, but the normal heart continues to pump out the same percentage of blood. Okay? And as you go throughout your life, or if you end up having problems, you'll start to see issues with your ejection fraction. All right, so blood flow within the heart. Blood from the upper part of the body returns to the heart through the superior vena cava. Blood from the lower part of the body returns through the inferior vena cava. In the lungs, the blood is oxygenated and carbon dioxide and other waste products are removed. Freshly oxygenated blood is returned to the left atrium through the pulmonary veins. After oxygenated blood has been delivered by the capillaries, deoxygenated blood is returned to the heart. it is coming down. All right, so pulmonary circulation. This carries the blood from the right side of the heart to the lungs and back to the left side of the heart. Systemic circulation is responsible for blood flow to the rest of the body. Systemic arterial circulation, it would be oxygenated blood leaves the heart through the aortic valve and passes into the aorta. From the aorta, blood is distributed to all the parts of the body. All right, hold on 1 second. All right, so let's talk about some pathophysiology. It's in every chapter, right? So chest pain or discomfort that is related to the heart usually stems from cardiac cell ischemia. Decreased blood flow to the heart muscle is what's going to be that ischemia. It's also when you have that decreased blood flow, you're going to have issues with it feeding the heart, that blood flow feeding the heart and the oxygen to the heart, which eventually is going to cause that portion of the heart to start to die. So the heart tissue fails to get enough oxygen and nutrients, and the tissue begins to starve, and then from there it's gonna die, and if the blood flow is not restored properly. So what's got to be done is that, or what could cause that, it could be from a clot, it could be from any type of hardening of the arteries, anything like that could cause that. Some plaque buildup. So one would be atherosclerosis. Most often, diminished blood flow to the myocardium is caused by a coronary artery atherosclerosis. Cholesterol and other fatty substances build up and form a plaque inside the walls of the blood vessels. Atherosclerosis can cause complete occlusion if it's left unattended or left to look out for, and when that does, you have issues. Damage to the coronary arteries may become so extensive that they cannot accommodate increased blood flow at times of increased need. All right, so there's a figure with an example of atherosclerosis, sclerosis, and how it causes, or what it looks like when it causes a reduction of blood flow. All right, so thromboembolism is a blood clot that gets stuck at a narrow area and blocks the blood flow at that point. And then acute myocardial infarction, or AMI, is when a blockage occurs in the coronary artery. A coronary artery, sorry. You see the blockage, you see where it's starting to grab my. All right, you see the blockage up in this blockage area. You see where it's starting to cause some ischemia due to the blockage just not being fed appropriately. So some major control factors, or some major controllable factors of atherosclerosis that you can control, are going to be cigarette smoking. All you got to do is stop. High blood pressure. All you got to do is diet and take medications. Exercise. Elevated cholesterol levels. Refer to last said statement. Elevated blood glucose levels, as in diabetes, you have to be able to regulate it. You mitigate it by being compliant, and also diet, exercise, things like that. Lack of exercise, that would help out a lot of that. Stress, de-stress yourself. Easier said than done, right? Get rid of the stress. All right, acute coronary syndrome. It's the term used to describe any group of symptoms consistent with acute myocardial ischemia. Myocardial ischemia is the decrease in blood flow to the heart. The signs and symptoms of these two conditions are very similar and treated similarly under the designation of ACS. So when you take a CPR class, it also, there's at the end of it, it usually mentions about ACS. There's a portion to it. Or an ACLS. Or any other. Alright. Angina Pectoris. Or pectoris. It's a brief period when the heart tissues are not getting enough oxygen. It's also called angina. It's defined as a brief discomfort that has a predictable character or has predictable characteristics and is relieved promptly. Angina pain is typically described as crushing, squeezing, or like somebody standing on my chest. Usually felt in the mid-chest, under the sternum, but can radiate to the jaw, the arms, mid-back, or the epigastrium. All right, so a lot of times you'll hear an EMT scenario that describes it as this. It'll give, a lot of times you'll hear this. You have an older gentleman generally that was mowing the lawn and started having chest pains. He's cool, pale, diaphoretic, blah, blah, blah. When you show up on scene, he's saying that he doesn't feel it as much anymore. It's pretty well gone away. But it happened while he was mowing the lawn, and now it's went away. And a lot of times that's the scenario that's built up for angina, for acute angina. All right, so a single episode of angina can be a precursor to a myocardial infarction. Stable angina occurs at a relatively fixed frequency and is usually relieved by rest or by medication. Unstable angina occurs without a fixed frequency and may or may not be relieved by rest or medication. Then you have what's called progressive angina, which is a stable or unstable angina that's accelerating in frequency and duration. So it gets worse and worse. All right, acute myocardial infarction. Most deaths from AMI are caused by dysrhythmias. Dysrhythmias can often be prevented or treated. The pain of AMI signals the actual death of cells in the area of the heart where the blood flow is obstructed. And angioplasty or percutaneous coronary intervention has shown to be the most effective treatment for AMI. Glad I didn't water the lawn today. Be flooded like it is now. All All right, so some signs and symptoms of AMI are going to be your sudden onset of weakness, nausea, and sweating without an obvious cause, chest pain, discomfort, or pressure, the pain, discomfort, or pressure in the lower jaw, arms, in your arms, in the back, the abdomen, or in the neck. Okay, you could possibly have an irregular heartbeat and syncope. What is syncope? Can somebody tell me what syncope is? Fainting, that's right. Some other stuff that may come up is shortness of breath or dyspnea, pink frothy sputum, and then sudden death. So some physical findings of AMI. You look at your general appearance. The patient often appears frightened, scared to death, right? The pulse increases as a normal response to pain, stress, or fear, or injury to the myocardium. Blood pressure may fall as a result of diminished cardiac output. The complaint of difficulty breathing is very common. And then patients sometimes experience an almost overwhelming feeling of impending doom. So some of the consequences of AMI are going to be sudden death, usually a result of cardiac arrest. Makes sense, right? The heart fails to generate effective blood flow, and that's what causes that cardiac arrest. Cardiogenic shock, heart failure, a variety of other lethal and non-lethal dysrhythmias may follow AMI, such as tachycardia, the heart rate greater than 100 beats a minute, bradycardia, which is a heart rate less than 60 beats a minute, ventricular tachycardia, so VTAC, everybody's aware of VTAC, rapid heart rhythm, usually at a rate of 150 to 250 beats a minute. You'll have electrical activity starts in the ventricle instead of the atrium. This rhythm usually does not allow adequate time between beats for the left ventricle to fill with blood. Ventricular fibrillation is disorganized, ineffective quivering of the heart, of the ventricles, caused by unorganized electrical activity. So to defibrillate is going to be what you're going to have to get into, VTAC, VFib, so defibrillation, which is shocking the heart with a specialized electrical current to stop all electrical activity in an attempt to restore a normal rhythmic beat. Okay, so it stops all electrical activity to restore in an attempt to restore a normal rhythmic beat. And then asystole, as you know, is going to be the absence of cardiac, electrical, and mechanical activity. And I didn't talk about PEA in here. Does it? Did I miss it? Nope, no PEA. So PEA is pulseless electrical activity. That's where you may see on the monitor a pulse or some sort of pulse, some sort of QRS or some sort of effect there. And but when you feel a pulse, there will be no pulse. It's just the electrical activity, which is worked on the same as if you were to have a asystole. So some physical findings of AMI. went too far. Ooh, that lightning was close. So here's some common cardiac dysrhythmias. Alpha is going to be, figure alpha is going to be sinus tachycardia. Figure Bravo is going to be sinus bradycardia. Figure Charlie is going to be VTAC or ventricular tachycardia. Delta is going to be VFib or ventricular fibrillation. And then Echo, figure Echo, is going to be asystole. Nothing. So there are some different variations. Sinus, all that means is that it's regular. So you could literally take right here and fold this in half and line up one of the QRSs, the tips right here, one of these tips. And if you line up, let's say the first one and the last one, if you line it up, the rest of them, if you hold it up to a light, will all fall on each other. You know, if you fold them in half, if you fold that paper in half, it'll fold up and they will fold up on each other. And that's regular. It'll be, every one of them will be the same or will line up with each other if you fold it in half. And that's how you know it's regular or it's sinus. That's how you know it's sinus. Same thing with this. These two tick marks down here, can anybody tell me how many seconds apart these tick marks are? That's right, 6 seconds. So those tick marks are in 6 seconds. And that's how you get your count. That's how you're going to get your rate, is from those tick marks. All right, and this is what we call coarse ventricular fibrillation, because it looks coarse, right? In some others, you may see where it's a little more lined out, and that's fine ventricular fibrillation. And this up here represents your lead. So this is in lead 2. Is what it's saying. All right, so cardiogenic shock. It's often caused by myocardial infarction. The heart lacks enough power to force the proper volume of blood through the circulatory system, and that's what's going to be it. It may be differentiated from hypovolemic shock in that the chief complaint, chest pain, dyspnea, tachycardia, heart rate, bradycardia or excessive tachycardia, peripheral edema. Remember that, fluid. Dysrhythmias in the heart if you have them hooked to a monitor or if you can feel it for whatever reason. Certain types of dysrhythmias. Jugular venous distension. Okay, crackles. When you're auscultating for breath sounds, you'll hear those crackles. All right, so the same initial evaluation and treatment as a patient reporting any chest pain. The signs and symptoms are going to be anxiety or restlessness, air hunger, like they're trying to get air. The pulse rate will be higher than normal. Why is that? Because they're not getting enough flow or good enough perfusion, which is lacking the oxygen, which is telling the heart to, Hey, you need to pump a little faster. I'm not getting enough oxygen to breathe correctly. The brain's not getting enough oxygen to do its job. You need to pump faster. So that's what it's going to cause. Also, the brain is say, hey, you need to get more oxygen in your lungs to help create this perfusion or get this perfusion done. And so you need to breathe faster. You need to breathe harder. So that's where the air hunger comes from. And the anxiety is from the lack of oxygen. The lack of oxygen in the brain starts to get anxieties from that. The blood pressure will fall below normal as well. It's also characterized by a rapid and shallow breathing, nausea, vomiting, and a decrease in body temperature. Why do you think it's a decrease in body temperature? What do we call that? Or what is usually it's a decrease in body temperature, yes, but a lot of times you'll start that flow from the hands and arms and legs to the core of the body, shunting, right? Because of shunting. So what's the treatment for cardiogenic shock, you ask? Well, I'll tell you. So the treatment for the cardiogenic shock are going to be position the patient comfortably, administer oxygen as needed to maintain an SpO2 greater than 94, and assist ventilations as necessary if you need to. Preserve body heat, treat for shock, right? Gain IV access or intravenous access. Get that IV, get her in there. Provide prompt transport to the closest, most appropriate emergency department. Give them diesel, right? And then call for a paramedic backup if it's available. All right, so let's take a 10-minute break. Yes, I sure will.
The next time you look at your budget and you see those hefty subscription fees for your PDF software, remember this: you've got a choice.
All right, so you want me to go back? Right there? No problem. All right, so let's go ahead and take a 10-minute break, starting meow. And we're back. Everybody see the screen? Everybody hear me? Awesome. Awesome. All right. So, cardiogenic shock. Where'd I leave off at? All right, let's talk about heart failure. So heart failure, this occurs when the ventricular myocardium can no longer keep up with the return flow of blood from the atria. Okay? Can occur anytime after a myocardial infarction, heart valve damage, or a long-standing high blood pressure issue. Usually happens between the first few months and the first few days after an AMI. So left-sided heart failure, the pumping function of the left ventricle can be damaged by coronary artery disease. Can also be damaged by diseased heart valves or chronic hypertension. The heart rate increases and the left ventricle enlarges to increase the amount of blood pumped each minute. It's called congestive heart failure because lungs become congested with fluid when the heart fails to pump the blood effectively. All right, so right-sided heart failure. If the right side of the heart is damaged, fluid collects in the body after showing up as swelling in the feet and legs. Or that's how it, I'm sorry, not after, often. It often showing up as swelling in the feet and legs. Dependent edema is collection of fluid in part of the body closest to the ground. And then pedal edema is swelling specifically in the feet and lower legs. Correct. So some signs and symptoms of right-sided heart failure are going to be orthopnea. The patient is mildly or severely agitated. Chest pain may or may not be present with this. Distended neck veins. Swollen ankles from pedal edema. The use of accessory breathing muscles. Fluid surrounding small airways. Small airways may produce crackles. So you may be able to hear crackles when you're auscultating. You have a productive cough. Very phlegmy. And then you'll have a delayed cap refill time. You squeeze that nail bed and do your cap refill. It'll be over 2 seconds. So a treatment for this patient with right-sided heart failure is going to be to obtain vital signs, monitor the rhythm, and administer oxygen as needed. Allow the patient to remain sitting in an upright position with his legs down. And then you'll gain IV access because you're going to need it. And be reassuring to the patient. Gather specific medication taken by the patient and take them along to the hospital. All right, so it also says here talking about nitroglycerin. So you're going to administer nitroglycerin if the patient's systolic blood pressure is above 100 millimeters of mercury. So it's got to be above 100 millimeters of mercury. It's contraindicative in below 100 millimeters of mercury. So systolic, the top number, needs to be 100 or above. But you still run a risk. Even then, you still run a risk of A, dumping that patient, and B, filling that patient with fluid. Because the vessels are going to open up, more blood and oxygen will be able to get to them, and that's going to cause issues with, it's going to create more edema. It can. Assess your patient. All right, pulmonary edema. When pressure in the capillaries exceed a certain level, fluid passes through the walls of the capillary vessels and into the alveoli. It may occur suddenly, as in AMI, or slowly over months, as with chronic heart failure. It's a common complication of myocardial ischemia, and without treatment, it can result in acute respiratory failure and even death. So, precipitating causes include heart failure, myocardial infarction, pulmonary embolism, hypertension, and cardiomegaly. Preload and afterload can greatly influence the buildup of pulmonary edema. Treatment is focused mainly on maintaining the airway, breathing, and circulation, and transporting the patient to definitive care. So that's really how we're going to do that. Pretty easy. So hypertensive emergencies. Hypertension is any systolic pressure greater than 140 millimeters of mercury, or so that's 140, that top number, right? Or diastolic blood pressure greater than 90 millimeters of mercury, because of the narrowing there. So this occurs only with a systolic pressure. So that hypertension, that's hypertension. Hypertensive emergency, it occurs only with a systolic pressure of greater than 180 millimeters of mercury and a rapid increase in the systolic pressure, or a diastolic pressure of 120 millimeters of mercury. Symptoms of a hypertensive emergency are related to the effects of the hypertension. So sudden severe headache is common. The position the patient in with the head elevated, and transport rapidly to the emergency department and establish IV access. Just establish access. Don't bolus them, because you don't want to create more issues, right? So don't be bolusing them. None of that. You need to monitor that blood pressure regularly. So aortic dissecting aneurysm. An aortic aneurysm is a weakness in the wall of the aorta. Okay, just a weakness in the wall. Dissecting aneurysm occurs when the inner layers of the aorta become separated, allowing blood to flow between the layers. Really? Normal for what? Did she say what it was normal for? Or he or she say? Were you dizzy or anything like that? Yeah. I know I went with it's been a couple of years ago. I ended up going because my blood pressure. I came in that morning to work, wasn't feeling right, felt a little dizzy, a little uneasy, standing, had a major headache. Went to the rescue, grabbed the monitor, put myself on the monitor, took my blood pressure. My blood pressure was 185 over 118. And I was like, yep, that's it. I'll be seeing you. So went to the doctor, and they gave me some medication for it. I hated the medication, quit taking it, changed my diet instead. And that helped out quite a bit. Where was I at? The primary, so uncontrolled hypertension is the primary cause of dissecting aorta aneurysm. Signs and symptoms may include very sudden chest pain located in the anterior part of the chest or in the back between the shoulder blades. The pain of dissecting aortic aneurysm usually comes on full force with 1 minute from 1 minute to the next. So there's a table in your book, table 18.1, if you're following along, that it compares acute myocardial infarction and dissecting thoracic aortic aneurysms. So patient assessment of this, of what we're talking about, we're gonna perform a thorough patient assessment no matter what the patient says, right? It's imperative that you recognize a sense of urgency for reperfusion when the patient receives no relief with medications. Throughout the call, provide emotional support to the patient and explanation for the family. So the scene size up is going to go a little something like this. Always ensure the scene is safe for you and your partner, your patient, and bystanders. Look for and address any hazards and assess the scene for potential violence. Identify the nature of the illness. So also remember not to become fixated on a specific condition. So your primary survey, you're going to form a general impression of the patient's condition to recognize and address any life threats. So decreased level of consciousness may be an indication of decreased perfusion to the brain. So keep that in mind. Perform a rapid full body scan of the patient. An AED should be applied as soon as possible if it's available. If the patient is pulseless, not breathing, apneic, or unresponsive. So pulseless, apneic, not breathing, unresponsive, put an AED on them, get them ready. You're about to work. You're about to get work done. Welcome to Jobtown. Quickly assess for any major bleeding that may need to be controlled or any substantial edema in dependent areas. Determine the rate, quality, and degree of distress of respirations. With cardiac patients, breath sounds may be affected by the presence of fluid buildup that crackles right. Auscultate the crackles or congestion that indicates pulmonary edema. You'll have to auscultate it. Listen. If it's available, consider the use of CPAP when it's needed, so you can push that fluid out of the lungs. Right? Get them breathing a little better. Get a little more O2 in their lives. After assessing the airway and breathing, you're going to assess the patient's circulation, right? Determine the rate, rhythm, and quality of the patient's pulse, right? Grabbing it, touching it. Assess the patient's skin color. The patient's skin condition, color, moisture, and temperature. As well as at the same time, you're going to do the cap refill time, and if there's skin turgor. All right, pinching that skin, and if it goes back, you're good. If there's some turgor there, or it stays a little pinched looking, or indentions, you may have an issue. Make a transport decision based on whether you were able to stabilize any life threats, and during the primary survey at that time. So some history taking. You're going to determine and investigate chief complaint and history of present illness. Not all patients experiencing AMI have the same signs and symptoms. A chief complaint of chest pain or discomfort, shortness of breath, dizziness should be taken seriously. Seriously. You're going to answer questions in a professional manner and provide emotional support to that patient, and determine whether the patient is experiencing chest pain or discomfort and whether there are any other signs and symptoms to that. Determine also whether the patient is having respiratory difficulty along with it. A lot of times they are. So ask about other signs and symptoms that are commonly found, such as nausea, vomiting, fatigue, headache, palpitations. And then obtain a sample history from there, right? Signs and symptoms, allergies, medications, past pertinent history, last oral intake, and events leading up to. Ask about medication allergies, like I talked about. Medication allergies, that's important. So there's on your table in the book, if you're following along, 18-2, it's going to list OPQRSTI questions for you. Some good questions to ask. So ask the specific questions to a cardiovascular emergency. Have you ever had a heart attack? Have you ever been told that you have had or that you have heart problems? Do you have diabetes? Or have you ever had any problems with your blood sugar? Have you ever had kidney disease? Do you have any risk factors for coronary artery disease, such as smoking, high blood pressure, or a high-stress lifestyle? Do you? All right, your secondary assessment. So you're going to evaluate the patient's circulation by assessing pulses at various locations and assess the skin color, temperature, and condition, right? In addition to the cardiovascular system, examine the respiratory system for signs of inadequate ventilation, right? You're going to auscultate for breath sounds for depth, equality, and any adventitious sounds, those odd sounds, right? The crackles and all that good stuff. Reassess the level of consciousness on your secondary assessment also. Make sure that you're trending as it declined, has it gotten better. Measure and record the patient's vital signs, including the pulse, respirations, and blood pressure. If you suspect a stroke or aortic aneurysm, obtain blood pressure readings in both arms and compare the measurements. So that burning, sudden chest pain, sudden severe burning chest pain, sudden severe burning back pain in between the shoulder blades, Repeatedly obtain those signs at appropriate intervals. Stable and unstable, right? So your reassessment for that patient, you're going to repeat the primary survey to check whether the patient's condition has improved or if it's deteriorating. If cardiac arrest occurs, you must be ready to begin automated defibrillation or chest compressions immediately. Quickly, be on it. So that means you need to be ready for it anyway. So provide prompt transport to the closest appropriate facility, giving them diesel, right? Treatments such as clot-busting medications and angioplasty should be started as soon as possible after the onset of attack. That's why it's important to give your field diagnosis, to be accurate with your field diagnosis. Report to the hospital by radio or cellular telephone while you're en route. Document your assessment of the patient. The patient's response to the intervention at the time of each intervention must also be recorded along with that. So some emergency medical care for chest pain or discomfort. You're going to treatment of the patient begins with proper positioning, right? So patients who don't tolerate being positioned supine might be allowed to sit up. You're going to provide oxygen as needed and maintain that SpO2 of what? 94% or higher, right? A patient who's unresponsive or in obvious respiratory distress may need assistance with breathing. You're going to give it to them. Use a bag valve mask or positive pressure ventilation device, so like CPAP or something like that if need be. Also, gain that IV access as long as it doesn't cause a delay in transport, because they need to get some yonder. Depending on your local protocol, you can prepare to administer aspirin and assist with prescribed nitroglycerin. So what that's going to do is going to relieve the pain of angina by increasing the vessels to increase oxygenation to the hypoxic tissue. It relaxes, and also it relaxes the muscle of the blood vessel walls and dilates the coronary arteries. It increases the blood flow and supply of oxygen to the heart muscle and decreases the workload of the heart. It also dilates blood vessels in other parts of the body. It can sometimes cause low blood pressure and or severe headache, so you want to be ready for that, right? And other side effects might include changes in the patient's pulse rate, including tachycardia or bradycardia. So to administer that nitroglycerin, you're going to check the condition of the medication and its expiration date. You're going to wear gloves when handling nitroglycerin. You're going to obtain permission from med control to administer the prescribed nitroglycerin, right? And you're going to make sure that you're going to follow protocols for administration of additional doses of nitroglycerin as well. Part of the zipper club there. Heart surgeries and cardiac assistive devices. Hundreds of thousands of open heart procedures have been performed to bypass damaged segments of coronary artery in the heart. You can see there the zipper scar. So some of the surgeries and devices: a coronary artery bypass graft. A blood vessel from the chest or the leg is sewn directly from the aorta to the coronary artery beyond the point of the obstruction. Patients who have undergone a bypass graft will have a long surgical scar on their chest from the procedure. Percutaneous transluminal coronary angioplasty aims to dilate the coronary artery. Chest pain in a patient who has undergone any of these procedures should be treated the same as chest pain in patients who have not undergone any heart surgery. Same. Pacemaker. So pacemakers are inserted when the electrical conduction system of the heart is so damaged it cannot function properly. It delivers an electrical impulse through wires that are in direct contact with the myocardium itself. If a pacemaker does not function properly, the patient may experience syncope, fainting, dizziness, or weakness. A patient with a malfunctioning pacemaker should be promptly transported to the emergency department. They now have pacemakers that have GPSs in them, or they had them for a while. They have GPSs in them, so they can find you if it's going off, or if it alerts a doctor. So the automatic implantable cardiac defibrillator, not the same as a pacemaker. Patients who survive cardiac arrest due to ventricular fibrillation have a small automatic implantable cardiac defibrillator implanted, or an AICD. It's attached directly to the heart, and the patient should be treated like all other AMI patients. Treatment should indicate performing CPR, beginning with compressions, and using an AED if the patient goes into cardiac arrest. All right, you also have the external defibrillator vest. It's a vest with a built-in monitoring electrodes and defibrillation pads. The monitor provides alerts and voice prompts when it recognizes a dangerous rhythm and before a shock is delivered. If the patient is in cardiac arrest, the vest should remain in place while CPR is being performed, unless it interferes with compressions. To remove, you'll have to remove the battery from the monitor and then remove the vest. Any patient who's wearing a device that has already delivered a shock should be transported to the hospital for further evaluation. Most definitely. Then you also have the left ventricular assist device, or LVAD. These are pretty cool little deals here. It's used to enhance the pumping of the left ventricle in the patients with severe heart failure. There's several types of LVADs. The most common ones have an internal pump unit, and external battery packs. It almost looks like a shoulder harness, almost. If you're unsure what to do when an LVAD malfunctions, contact Med Control for assistance. Transport all LVAD supplies and battery packs to the hospital with the patient. So a lot of times they'll have 2 batteries on it, and one battery is there, one battery is a backup, then they'll have extra batteries there. It lets them know well in advance when a battery is going dead. It'll start beeping. As well as some of those LVAD patients, you'll see the tick marks there on a monitor. It looks crazy. It looks like and some of them looks like no heart rate whatsoever. It just, it's wavy. And then you'll see these tick marks all up and down it. And you have the same thing with a pacemaker or a pacemaker. You'll see tick marks on the monitor. But the LVAD, you can hear it as well. You can hear it working. If you were to auscultate the heart, you could probably hear some sounds of it. You're not going to get a reliable blood pressure all the time from somebody that wears an LVAD. They also have GPS devices that, if need be, it'll go off and then it'll alert their doctor, and that patient will be put into the transport system before you even get called. A lot of times, so because they have to show up to a doctor whenever that thing starts to malfunction or anything else. If you ever run across a patient with any of these devices, they could probably tell you more about it than you'd ever want to know. I would ask about them. Ask about them and see what they're about. See what different types of issues that they have with them or what have you. All right, so cardiac arrest. Cardiac arrest is complete cessation of functional cardiac activity, either electrical, mechanical, or both. It's indicated in the field by the absence of a carotid pulse. Absence of that carotid pulse. And it may be the result of trauma or numerous medical conditions. If you have a traumatic cardiac arrest, you have approximately a 0.0000000001 chance of coming back due to CPR from a traumatic cardiac arrest. It's very slim. All right, so automated external defibrillators. Portable automated defibrillator can automatically administer an electrical shock to the heart when needed. All models of AED machines require a certain degree of operator interaction, beginning with applying the pads and turning on the machine. Many AEDs use a computer voice synthesizer to advise the operator what steps to take on the basis of AED analysis. Some of them even tell you they'll have a tick sound like a metronome for CPR. And now even they'll tell you to push harder, push harder. So AEDs or fully automated AEDs deliver the shock automatically. There are a few fully automated AEDs left. AEDs also come equipped to give a monophasic shock or a biphasic shock. A monophasic sends the energy in one direction from negative to positive. Biphasic sends the energy in two directions. So some advantages of AEDs. The machine is fast and delivers electrical shock to a patient in VFib or pulseless ventricular tachycardia. Sends it. It can be delivered within 1 minute of your arrival at the patient's side. It's easy to operate, and paramedics don't have to be on scene to provide that critical intervention. Shock can be given through a remote, and then also adhesive defibrillator pads. So remote adhesive defibrillator padding. Don't try to use the sticky no more as hair removal. It doesn't work the same anymore. The sticky's not the same. So some of the rationale for early defibrillation, there's 5 links in the chain of survival, right? You got recognition of early warning signs and immediate activation of EMS. You've got immediate CPR with emphasis on high quality chest compressions. You got rapid defibrillation. You got basic and advanced EMS care. And then you also have ALS and post-arrest care. Putting them on that dopamine. If any one of the links in the chain is absent or delayed, the patient's chances of survival start to diminish. Rapid defib is the greatest determinant for survival in this. Defibrillation works best within 2 minutes of the onset of the cardiac arrest. 2 minutes. All right, so integrating the AED and CPR, you got to know how to work the AED into the CPR sequence. Don't touch the patient while the AED is analyzing the heart rhythm and delivering shocks, because what does that do? Firemen love doing CPR. That's not true. So you don't want to touch that patient. Stop CPR and let the AED do its job. Okay, so back off. When it says that it's analyzing, back off, because you touch the patient, it may seem it as being a rhythm, and then it's not going to deliver a shock, or it's not going to advise that you deliver a shock. So some things also, AED maintenance. Become familiar with the maintenance procedures required for the AED. For fire department personnel, you just don't throw the damn thing in your truck and let it sit there. You have to do regular checks on it, regular inspections on it. Read the operator's manual. That's going to be very important. An error is usually because failure to charge or maintain the AED, failure to use the AED correctly, application of the AED to a patient who has a pulse. If the AED fails while you are caring for a patient, report the problem to the manufacturer and the U.S. Food and Drug Administration, the FDA. Med direction. So the medical director of your service should help to teach everyone how to use the AED. In most states, AED training in an AMT course is not permitted without approval by state law. Rules and also local medical direction authority. There should be a review of each incident in which the AED is used. There should be a run review for each incident that an AED is used. You should be talking about it anyway, with HIPAA in mind, after it's over. Taking care of the unit is the biggest thing. You've got to check that thing off. Make sure you're looking at it. Make sure the battery's full. Open it up and listen to that. Remove all clothing from patient's chest. So you'll hear that. Make sure you follow the directions. Close it back up. Check the battery. Also see if there's a maintenance marker. Turn it over. Make sure that it's within its yearly inspection, because it's supposed to be inspected yearly. We do regular visual inspections of ours once a week. That's for the buildings in our first in area as well. Do not defibrillate a patient in pooled water. Remove any medication patches. That's a good one. Shave a hairy chest. So you're going to have to expose your patient. Shave that chest. Shave it, shave it, shave it. Don't try to do the sticky pad thing and ripping it out. It does not work the same way. Use the shaver that you have in there, the razor. Do your regular change outs for CPR. Make sure you got somebody that can change out with you. And you need to do it as quickly as possible, almost like a flow. Do you remove rings from the chest? I'm sorry? Oh, like nipple rings. Yes, jewelry, I would. those piercings. So you need those medication packages. Yeah, they can leave a little burn mark. Those medication packages or patches, I mean, you need to make sure if it's a nitroglycerin patch or anything like that. You just got to make sure that you remove those. Wipe the area with dry gauze before defibrillation because they can actually ignite. So those patches they can burn. And then also, there's also indications for not initiating resuscitative techniques, and this includes rigor mortis, dependent lividity, and decapitation, right? Brain matter everywhere, that would be a pretty good one. Big important thing, get that IV dog or that IO. IV or IO. Do not hesitate to do the IO if you got the availability to do so. Yeah. So patient care after automated external defibrillator shocks. You're going to follow your local protocols. Patients who are successfully defibrillated by an AED will develop a normal heart rhythm, which is awesome. Patients who do not regain a pulse on the scene of a cardiac arrest usually do not survive. Further steps, depending on your EMS system's protocols, you can take afterwards. If there's depending on time, how long you've been resuscitating a patient, and you haven't had any change or any rhythms. If a paramedic's responding to the scene, the best option usually is to stay where you are and continue the sequence of shocks and CPR. If you transport a patient while performing CPR, you need a plan for treating the patient in the ambulance. So there's a figure that shows the AED algorithm. So, cardiac arrest during transport. If you're traveling to the hospital with an unresponsive patient, check the pulse at least every 30 seconds, right? If a pulse isn't present, stop the vehicle. If the AED is not immediately ready, perform CPR until it is available. Analyze the rhythm. Deliver one shock if indicated, and immediately resume CPR. Continue resuscitation according to your local protocol. After that. If you're en route with an alert adult patient who's having chest pain and then they become unresponsive, so you're going to check their pulse, stop the vehicle if no pulse is present. If the AED is not immediately ready, perform CPR until it's ready. Analyze the rhythm, deliver one shock if indicated, immediately begin CPR. Begin compressions and continue resuscitation efforts according to your local protocol, including transporting the patient. So let's talk about ROSC. So, return of spontaneous circulation, which is going to be restoration of the pulse after cardiac arrest. You're going to monitor for spontaneous respirations. Provide oxygen via bag valve mask at 10 to 12 breaths a minute to maintain an EtCO2 between 35 and 45 millimeters of mercury. So what right there does that tell you that you should have attached to your BVM, right? Your EtCO2 monitoring device. That's right. Have it attached. If you're in there, do it. Maintain an O2 sat between 95 and 99%, and then assess the blood pressure and determine if the patient can follow voice commands from there. Transport the patient closest to the closest appropriate facility depending on your local protocol from there. So there's some cardiac monitoring there. Some EMS systems will allow to place electrodes, attach the leads, and obtain an ECG tracing prior to transport. For an ECG to be reliable and useful, electrodes must be placed in consistent positions on each patient. So even here, this is technically not a true placement here. This is what it's telling you. True placement is actually on the shins and then on the forearms. But for these purposes here, put them here. Put them here. Who remembers any of the sayings that go with this? White to the right. Smoke over fire. So black smoke over red fire. White to the right. And then green grass. Yeah. That salt, pepper, lettuce, ketchup, that was so stupid to me. I was like, forgive me. I was, so this has been a couple years back. I haven't heard, for a 5 lead. I hadn't heard of the salt, pepper, lettuce, ketchup. It doesn't make any sense to me, first off, because look, clouds over grass, smoke over fire. So white to the right, clouds over grass, smoke over fire. That makes sense to me. Salt, pepper, lettuce, ketchup does not make sense to me whatsoever. I don't know how that makes sense to anybody unless you worked at Burger King or McDonald's or something. I don't know. Flip burgers before you did this, which I don't know why you would leave, because you probably make more money flipping burgers now than you do in an ambulance. But so we were sitting on scene, and I had this patient, and I had a new AEMT was sitting there with me. I think it was a new AEMT. So this person comes in, it's brand new. Yeah. So she comes in, and this person automatically has got an attitude for authority. Somebody that she doesn't want to listen. She do her own thing. She gets it. I get it. She had no clue. In her 1 minute of experience as an AEMT, it was. So what I always do with my new recruits or with new people coming in is I hand them a pad and a paper. Take this pad and paper, go sit over there in the corner, and write down what we're doing. Write down what you see the whole crew doing. And this is how it's done. You start off writing, and then you'll start working. Sooner or later, you'll just get into the mix. So anyway, we get down there, and she shows up, and I'm working with this patient, getting an IV and everything, and I look up without thinking, and I said, if you would, go ahead and put the leads on this patient. I said, and I looked, and I realized it was somebody new. I was there by myself. Somebody was just walking through the door, some other person, and she gets down there, and she's got these leads in her hand, and she starts this salt, pepper, lettuce, ketchup. And she's sitting there, salt, pepper, lettuce, ketchup. And I said, I couldn't help it. I said, what the hell are you doing? Are we making lunch, or are we doing patient care? Are we making lunch? We're doing patient care. I said, what are you doing down here touching my stuff anyway? Here's your notebook. Here's your paper. Get up there and write. Automatically, you have. When she said the salt, pepper, lettuce, ketchup, I had no clue what she was talking about. I was like, oh my God, get out of here. Get out of here with that. We're not going to set that. Plus that, you're doing that in front of the patient, which doesn't look really good anyway. So I've always used the white to the right, clouds over grass, smoke over fire, and then brown in the middle. Shit in the middle is what people used to say. Or shit on the chest, or whatever you want to say, if you got a 5 lead. But we don't. So, anyway, that was my little story on that. Eventually, she ended up being a good AEMT, I guess. Eventually. All right, so some guiding principles. So guiding principles, shave the electrode site. So you don't have to shave the whole chest, but just right where you know the electrodes are going to be, you can shave that area. And then, all right, you're going to rub the electrode sites with alcohol swab. What that's going to do is going to dry it, because those things pop off all the time. If they're diaphoretic, it's going to pop off. If they're diaphoretic, they're going to come off. You're going to attach the electrodes to the ECG cables before placement. And then when all electrodes are in place, switch on the monitor and print the sample rhythm strip. Okay. So you can see the picture here. All right, you can see the heart in the background. All right, easy way to remember this. You got the 4 down right here, right? So what's next is leads 1 and 2. V1 and V2. Right here, one side. Right here on the other. Matching. They need to match. Wherever they're at, they need to match, right? Then from there, I'm going to show you. So these need to be matching across the way, right? So from there, I skip V3. Skip V3, and I go straight to V4. All right? Why do I do that? Because V4 is mid-clavicular line, straight down the nipple line, or straight down, mid-clavicular, straight down to that intercostal space between the 5th and 6th intercostal space, and then you hit it right there. So now you got 1 and 4 right there. Guess what goes in the middle of 1 and 4? Right in the middle of 1 and 4, to make up the difference, is 3. And that's how you remember that. In the middle of 1 and 4 is 3. And then from there, you come across, you got that. From there, I come across a little bit further back. All right, about midway between mid-axillary and 4. Mid-axillary and 4, I put my 5. And then I put 6 mid-axillary. And that should be right there. In between all of them should be in the 5th and 6th intercostal space. Okay, in between the 5th and 6th intercostal space. So between the ribs coming up. And you don't come across, and then when you come across, you don't just come across and then go straight. Because your ribs don't just go straight, right? They curve. All right? If you're working with if you don't want to work around a bra or anything like that, move it out of the way, take it off, whatever you need to do. Move the shirts and everything else, anything else they have that's in the way. And also, if you're having to move a breast, whether it be on a man or a woman, if you're having to move that breast up or down or what have you to get to that intercostal space or that 5th and 6th intercostal space, what you're going to do is with your gloved hand, you're going to use the back of your hand to lift. Okay? It's a more professional way to do it. It takes a little bit of the edge off, what have you. With your gloved hand, use the back of your hand to lift, and then place your electrodes. And then you can put it back down. You can put the breast back in place. Male or female. Doesn't matter. But yeah, on 6, just because here you couldn't get a good view, mid-clavicular is where that 6 is going to go. A lot of times to find that intercostal space, if you raise an arm up and you look, you'll see a triangle underneath the arm where the armpit's at. You'll see a triangle, and right at the tip of that triangle usually is really damn close to where your 5th and 6th intercostal space is at. Any questions about any of that? There's a skill drill on that for performing monitoring. I always recommend going to a 4-lead, 12-lead class. I think they are fantastic. You can get a lot of good information out of them. So if you ever find one or can get into one, make sure you get into it. All right, that is the end of that slideshow. So let's do this. Let's take a 10-minute break, come back, and then we're going to do a few patient assessments. Okay? We're going to do a few patient assessments. So let's take a 10-minute break and then come back. Check out your local protocols. It's all about your local protocols. All right, 10 minutes on the clock. I don't know what happened to my internet. We're trying to get it figured out. I guess the storms knocked it out, so I had to get on with the Wi-Fi or MiFi. We'll see how stable that gets. All right. Does anybody have any questions about Chapter 18, Cardiovascular Emergencies, before we move on to our next bit? So I hadn't got to talk to Rob, but I was thinking more of the only way I can attend. The dates as of right now are as they were, but in order for me to attend, I can only do it. Oh my goodness. I can only do it the 18th and the 19th. That's the only way I can attend. Usually he does the boot camps with the EMT class, but I'll have to ask him if we can do it for the 18th and 19th. Let's see here. Tell him to eat it. I'm checking my stuff right now. It's long and arduous, and it's the hardest thing that you'll have ever done in your life. You're going to get your teeth kicked in every single day. It's awesome. Hold on. Okay. So we can move it. We can move it so long as everyone in the class can move their date. If they cannot, If they cannot move their date from the 11th and 12th to the 18th and 19th, then we will have to keep it on the same day. And at that point, it is what it is at that point. But if everybody agrees that they can move their trip, if they haven't already scheduled it, to the 18th and 19th, which I believe is the correct days, right? Saturday the 18th, Sunday the 19th. But it has to be in full agreement. Since it was already on the syllabus, it's almost like a business plan deal. We have to all be in sync for it. So if everybody can do that, if it's possible, then we can change it. If we can't change it, then, or if everybody can't do it, then we have to keep it the same day. Does that make sense? Hold on, I'm asking. Did everybody stay in Wiggins last time? Okay, where did everybody else stay? Just came down for the day? I'm not worried about where the instructors stay. Just the students. That sounded ruined me. Well, generally, there's I think last time they set up hotel rooms, or they had the availability to set up hotel rooms at a discounted rate. Who stayed in Wiggins last time? Anybody? Okay. Hey, Mr. Martinez. So we're trying to get a better game plan for this boot camp, seeing as how it's coming up. One of the things was if the possibility of being able to move days from September 11th and 12th to possibly the September 18th and 19th. If that were possible, if everybody can do it, that's fine. If somebody can't do it, then let me know, and we won't do it. We'll stick with the original schedule since that was the original schedule. Okay. I just got to get the consensus for everybody. Don't feel like you have to tell me here. If you need to send me a message personally, please do that for whatever reason, and I'll we can take care of it from there if there's any issues. I do really want to help with making it as quality as possible. I think that's going to be the goal that I'd like to get out of this, most definitely. Does anybody have their syllabus handy by any chance? To tell us what we're supposed to do on it or what our subjects are? Medical assessment scenarios and BLS assessment scenarios is what it is. So that should be easy peasy stuff, and then we can go over other types of things from there. All right, I'm being told that Poplarville was the most central location. I don't know. I wasn't at the last one. I think somebody accidentally got stuck with a EpiPen. We don't technically need IV arms, so we can choose another location and probably get some dummies there, no issue. We would just have to make sure that we either rent the space to do the labs at, or what have you, like the practicals, like a conference room or something like that. All right. Did anybody else make it back from my long sabbatical out of here? I don't see anybody else answering. Like I don't see Hannah answering, Matt, Leanne, Miss Torrance. Do we lose all of y'all? Okay. But yeah, if we can do those, if depending on what. Okay. 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 Mr. Martinez said it was okay. Okay. And we'll have, I'll have to talk to Rob about it and see if there's anything. Uh, we do have some medical administration, which may limit. It may limit what we can do. And if that's the case, I'll see what I can do about grabbing some stuff and maybe getting it to a better location. I'm just trying to think of better locations where we can all, we maybe not so much Poplarville Fire Department. Maybe there's a better location if we're going to do both days. Because I would actually like to do both days. I think we could fill it up with some really good information. The 1 day deal, it's kind of hard to make sure that you get all the information that you need. Plus that, and we may be able to knock down some of these chapters, 1 or 2 chapters or something like that. We'll do like a live in-person class or something to that effect for a piece of it, and knock something down that may be holding us up. Hold on right quick. All right, but we'll keep looking at that, and see what we can do. If we can't get it moved, then we'll have to rock on with the same day. If that's something that we have to do, because either it be logistically impossible or something like that, especially with everything going on right now, COVID and all that. That may be something else that we have to look at too, is the possibility of not being able to do one because of COVID or breaking it up, quite possibly having to break it up, which, would be taxing on the instructors getting there, what have you. But that's our job. So that's something that we can definitely figure out just to keep the contact level to a minimum. So we'll definitely figure that out. This kind of everybody's in flux right now. I know that we do a lot of, like in our county, for example, it's mask everywhere you go. You don't leave the room without a mask or anything else. At one point, they were wanting to make masks no, we're not doing it at Miller's house. We're not doing it at Miller's house. It's not enough room. You can't social distance at Miller's house. That's way out there. So we'll get something figured out, though. Hopefully by Wednesday. We saw that we have a good number here. But we'll get something figured out. No, I haven't seen the new place. The new place where? Yeah. Oh, he lives in Biloxi? Didn't know that. he was best man at my wedding, and I don't even know where he lives now. It's crazy. So anyway, moving on. We'll get that figured out by Wednesday. I'm gonna keep texting you about it. Check your Discord, check your emails, and let's check. Actually, I'll put it out on our messenger through not Canvas. Got Canvas on the mind right now on JB Learning. So I'll put it out there in JB Learning on the messenger to everyone, so we can get out there and make sure that we stay hemmed up with it. I'll try and get some better answers by tomorrow evening, is what I'll try to do. Okay. Other than that, let's move on to some good stuff. First off, let's talk about this. The 4-digit code before my email decides to go, or before my internet decides to go away. I have no clue where we're at with FizDat. Why, are you taking rides? Are you doing rides right now? I'll have to contact our coordinator and make sure everybody's getting set up in the FizDat. We just got the, yep. I think a lot of things is dependent upon COVID. There's a lot of COVID stuff going on, so we're kind of in flux with all that stuff right now. All right, so Chapter 18, 4-digit code, 4235. 4235. All right. So let's look at some practice scenarios. All right, here we go. I'll take a volunteer first. Who wants to go first? Nobody wants to go first? Mr. Wade, you want to go? All right. You can put your mic up. Mic on up. If you're able to. All right, then. All right, here we go. EMS 10, respond to Jay's Liquor Store for shots fired. It was reported there is a man down. Go.
BSI is my scene safe.
Scene is safe. What are you going to wear?
Gloves and eye protection.
There you go. Gloves and goggles. All right. Scene is safe. PD has secured the scene.
All right. Mechanism of injury would be a gunshot.
Mm-hmm.
How many patients do I have?
You have one patient. There's a large crowd.
Okay. I'm gonna get ALS en route for sure.
All right. They on the way. They're going to be 10 minutes out.
All right. I mean, I would put a seatbelt on them if they could, but I mean, it's really a life threat, right?
I'd go ahead and put it on them. You're right. So, due to the man down, right? You're gonna bring it. You're gonna bring it. All right. Keep on trucking. You're in the primary. I'm sorry. Repeat that.
What's my general impression of my patient?
The patient's sitting slumped over against the building.
All right. Is he conscious? Responsive?
Let's say so. Sitting against the building. You see the bullet hole in the lower left chest. He withdraws to painful stimulus. Your chief complaint is going to be GSW.
All right, I'm gonna assess his airway.
Okay. So you see secretions in his mouth.
All right, I'm gonna suction his airway.
Okay, how would you do that?
With a catheter thing.
With a yonker?
I guess
all right. So how? Walk me through the procedure of suctioning.
I guess lay him down.
Okay.
Jaw thrust to open his airway. Use the catheter. Suction no more than 10 seconds.
In which direction?
I don't know.
Only suction on the way out, right? So we're going to cap it, and then we're only going to suction on the way out. Okay? 10 seconds on the way out.
Okay.
Okay? All right, so what's next?
Can he... Does he have a patent airway, or do I have to manually?
His airway is now patent. It's now open.
Okay. What's his breathing rate?
His agonal respirations.
All right. I'm going to get my partner to ventilate for him.
Okay.
With oxygen, 15 liters.
Okay. All right. What else are you going to put in there?
OPA.
There you go. All right. What's next?
Did that help him?
I hope so. He's taking breaths.
Okay. I would check a pulse, but I mean he's breathing. So.
Okay.
What's his skin temperature? I mean skin color and temperature.
Circulation, right? So it's his cap refill time is more than 2 seconds. There are no active bleeds. His heart rate is slow. His skin is pale, cool, and diaphoretic.
All right, I'm gonna go ahead and hold direct pressure to the.
There's no active bleeds.
Oh, okay. I guess treat for shock. Start a line.
Okay, tree for shock. There you go. Get a line started. All right. What's next, D? There's no disabilities. E. What is E? A, B, C, D, E.
Exposure.
Exposure. What are you going to do with this patient as far as exposure?
Cover him up.
You got to expose the whole body. You got to check him, right? This is think. So yeah, you want to expose the whole body. Get him stripped down, and then you can still do that, but you just check underneath the covers for all your stuff, right? Or underneath that blanket. But you gotta uncover him so that you can see everything. Make sure there's no extras. All right. All right. What's next?
I'm definitely going to transport immediately.
Yep. That is true. What hospital would you want to transport this patient to? What type of hospital?
Trauma center.
Yeah. Okay. Alrighty. What other type of interventions are you going to try and get up on this patient as well? You said IV, so how, like what size IV?
A large one.
A large one? Like what gauge would you start off with, you think?
Probably like a 18.
The go-to. Yeah, 18. Possibly 2 18s, right, if you needed to. All right. All right, go ahead. What's next? You got the patient loaded up in the ambulance. Rock and roll.
Get a baseline set of vitals.
Okay. You got vitals are going to be, first set's going to be 92/64. Eyes are pearl. LOC is ANO times 0. His lung sounds are diminished on the left side. Got agonal respirations and a pulse of 58.
So he has a pneumo.
Remember, follow your process. You can do it kind of quickly, but you're going to follow your process all the way through. You're doing good.
I can't sample history. He's unconscious. He's unconscious.
Yes, ANO times 0.
Okay, so I can't get a sample.
Yep, you're not gonna be able to get it. So you announce that he's unconscious, so I can't get OPQRST or sample. That's right. He looks to be around his mid-30s when you get to the age part. Signs and symptoms are gonna be GSW, right?
Yeah.
and in altered level of consciousness, AMS, because ANO times 0. All right, what's next?
A secondary assessment.
All right, let's go.
All right, I'm gonna inspect mouth, nose, and the face.
No, nothing remarkable.
OPQRST. Looking for
Nope.
abrasion.
DCAT BTLS, remember?
Oh yeah, DCAT BTLS.
I knew what you meant, though. All right, so his head, I don't see any, I don't feel anything when I'm shampooing his head. I don't see raccoon eyes in his ears. I don't see anything coming out of his ears. I don't see anything coming out of his nose. Open his mouth. He's got all of his teeth. Maybe he's got all of his teeth that were there before he hit the ground. Let's say that. I don't see anything really in his jaw or anything like that. No broken facial bones or anything like that. Okay, no battle signs, nothing like that. So head is good. What's next?
The neck.
What am I looking for?
JVD.
Okay, he does have JVD.
Tracheal deviation.
He does have tracheal deviation.
Okay, so he does have a pneumo.
It's going the tracheal deviation. It looks like it's deviating to the right.
So it goes to the good lung.
Mm-hmm.
Alright. I palpate the surface of spine.
I'm sorry, I couldn't hear you.
Palpate the surface of spine.
Nothing remarkable.
Okay. The chest.
All right, what am I looking for?
A gunshot wound.
Okay, so you do see a sucking chest wound over there on the left side.
All right, I'm gonna put an adhesive dressing.
Okay.
Tape it 3 sides.
All right.
And also tape both sides.
Okay. So at this time, you don't. Nothing's going on yet. So how are you gonna be able? So when you saw that sucking chest wound, that lets you know what may possibly be going on, and the deviation and everything else. What did that mainly lead you on to?
It's a tension pneumo.
Okay. And how would you identify that?
The deviation of the trachea.
Okay.
Diminished lung sounds.
Okay. If he's getting harder to bag, right? Okay, so you do have the availability of a chest seal. You'd put that on him. Put your little chest seal on him. Okay. All right. What's next?
The abdomen.
He is getting a little easier to bag, by the way. Abdomen, nothing remarkable.
All right. Check his pelvis.
Checked his pelvis, nothing remarkable.
All right. Does he have a prior prism?
He does not.
Okay. Check the lower extremities now.
All right, good to go. Nothing remarkable.
Okay. And the upper extremities.
Nothing remarkable.
All right. Roll them onto his side.
Okay. What am I looking
check
for?
His back.
Okay. What am I looking for?
Any exit wounds?
There is one. What you gonna do with it?
Just seal it up on both sides.
Seal it up. There you go. Okay. All right. What's next?
Manage the secondary injury.
Okay. All right. It's been 5 minutes.
Check the vitals again.
Okay.
Also take lung sounds.
All right. So blood pressure is going to be 90/60. Eyes are pearl. He is A&O times 0. Lungs sounds a little diminished on the left, not as bad as it was before. He's got the breathing starting to come back. He's pale, cool, diaphoretic. He's still a little agonal, and pulse is 60. All right, so you're picking up the phone or you're picking up the radio now. How are you going to send that report in?
I think you said medic 10, so medic 10 to hospital.
Go ahead.
I'm en route to your facility with a 38-year-old male, GSW, lower abdomen. Blood pressure is 90/60. A&O times 0. Lungs are diminished a little bit on one side. Skin pale, cool, and clammy. Pulse is 60.
Okay. What's his respirations?
Oh.
Agonal.
Agonal.
Agonal respirations. All right. Did you do anything for him?
Yes, I gave him an OPA. Assisted his ventilation. Sealed his chest with a chest sealant thing.
Do you have an exit wound?
Yes.
Great. Other questions I might ask. What other type of interventions did you give?
Supplemental oxygen, that's about it.
Did you put him on any fluids?
Oh yes, I did.
Where at? We gotta have a good. Have to have a good patent IV.
I guess both arms.
Sounds good. You bolusing him right now?
Yes.
With what? That's not good. That's not good. What would you bolus him with?
Are you talking about what I give him?
Fluid. Like what type of fluid?
Sodium chloride.
Normal saline, right?
Yes.
Give him normal saline. Okay. All right. Right now I'm giving him a normal saline bolus. Okay. Alrighty. All right. How far out are you? We'll say you're about 5 minutes out. We'll say you're about 10 minutes out. I understand that I told you you're going to have ALS, but I need you to give a report. So I went ahead and let you give a report. All right. Good job. So when you start getting into those, you gotta keep your flow, and like I said, keep that process. Write stuff down and keep that process. Even though you know he's unconscious, you can still say his signs and symptoms. He's still a GSW with altered mental status, right? Signs and symptoms. You can't get OPQRST. You could say that. I can't get an OPQRST because he's unconscious or he's A&O times 0. Can't get a sample history because he's A&O times 0. He looks to be around his mid-30s. And then from there, you go down. You go down from there. That way, you keep it consistent every time. Like we talked about, the scenarios with medical are damn close to the same as your trauma scenarios. So if you just keep it the same every time, and you adjust as you go, then you'll be better for it, right? It'll be easy. It'll be that much easier to remember. Remember your vitals, and how can you make those vitals better? That's going to help you out a lot. Those interventions at ABC, and then how can make those vitals better, or those interventions at your primary, and then how can you make the vitals better, are very important as far as the treatment. And they may ask you, walk me through how you identified the tension pneumothorax. How did you administer oxygen for this patient? And even ask 100%, 15 liters, 100% oxygen, 15 liters a minute by BVM at, a rate of between 4 to 6 a second, something to that effect. So you put that in there. All right. Very good. Very good. All right. So I'm going to cut it off right there today. Like I said before, our code is going to be 4235. That's going to be get you a test. Don't forget, there's a discussion question there. So we'll take a look at that, read it, and it'll be due by, the discussion question will be due by Friday. The test will be due by Wednesday. We will also, I'm going to have a further discussion with Mr. Roy about the boot camp. See what we can come up with as far as all things considered, and then we'll move on from there. See what's going on. Also about the FISDAP, and see where we're at with that, because I know it's coming up. We got to start either looking at the COVID long game, or what's going on. All right. So that's all I have. Does anybody else have anything for me? All right. If not, I appreciate it, ladies and gents. FISDAP. So FISDAP is the computer program. You should see a label about it in your JB Learning. Whenever you start doing your clinicals or your ride-alongs, anytime you get a patient, first off, they're scheduled through FISDAP. Second off, your patient assessments and your patient documentation are done in FISDAP. Everything is done in FISDAP. So every time you get a patient and you work with a patient, you'll be doing a documentation on that patient in FISDAP. And we'll be going over that and training on it. Look over documentation. I know some of you have experience with documentation. This is only going to help you hone on it. I asked you before to make sure that you look at SOAP notes, you look at chart. So the chart method or chronological method, we'll be doing the chart method in here. So take a look at that chart method. CHART. I'm not typing on anything. Yes. Yes, Leanne heard it. We were talking about it. So with that, I will get off here. And you guys and girls enjoy the rest of your night. And if you need anything from me, please let me know. All right? Be safe. Bye.